All right, welcome everybody to the Friday UAB Informatics Institute PowerTalks seminar series. I'm very happy to introduce today's speaker. Dr. Melanie Besculides is an assistant professor in population health science and policy, and also the Institute of Healthcare Delivery Science at the Icahn School of Medicine at Mount Sinai. Her work and research has focused on clinical informatics, patient monitoring, perioperative care, and improving quality. And the name of her talk is Implementing a Machine Learning Screening Tool for Malnutrition, Insights from Qualitative Research Applicable to Other ML-Based CDSS.
Thank you so much for the wonderful introduction. I appreciate it. And thank you all for coming today. I know it's a holiday for many people, so I appreciate you taking time out of your busy day to come. So this is our study team. As you know, it takes a village to do anything. On the left is the study team for the qualitative study, which is what I'll spend the majority of today talking about. And on the right, I will touch base. This is sort of a three-phase study, three-part study. I'm going to spend most of the time talking about the qualitative piece, which is phase 2. But there's also quantitative pieces of the evaluation. One is the building of the machine learning model that I'll talk about, and then the evaluation of outcomes. And the team on the right was part of those pieces. So I just wanted to give credit to everybody that's been involved in this project. It's really a lot of different people with a lot of different backgrounds. From data science, we've got physicians, we have nutritionists, we have epidemiologists, nurses, just about everybody you can imagine on the team, which is great. So I just wanted to give you a little roadmap of the talk. I like to sort of outline how I'll be doing things, what I'll be talking about. First, I'll just touch on the importance of machine learning, which I assume you all know, but I always like to sort of frame the talk and why it's important. And then we'll talk a little bit about the importance of evaluating machine learning and talk a little bit about some of the methodology that we can use to do that. Then I'll talk about machine learning use in malnutrition screening, which is the machine learning program that we implemented at Mount Sinai, one of them. And then the 3 phases of the mixed methods evaluation. And most of that, as I said, will be spent talking about phase 2, the details, the methods of the qualitative research, the results, and the implications. And then I'll leave some time for questions and discussion. So in thinking about machine learning, we all know that it's incredibly popular. It's incredibly appealing. Obviously, we can process massive amounts of information with a computer in ways that humans just aren't capable of doing. So that's great. But machine learning techniques have been really criticized for their limited usability, their interpretability, and their effectiveness, especially in the clinical care setting. So if we have these things that can predict, but nobody uses them or nobody understands them because they don't want to use them, it's sort of this, well, what's the point? We spend a lot of money, a lot of energy in creating these things, which really do have the potential to really change clinical care and what we do, and to save time and to save money. But if nobody trusts them, if nobody uses them, if nobody knows how to interpret them on the clinical, on the user end, then they're sort of useless, and we're just wasting time. So this is where evaluation becomes incredibly important. It's really critical to our process. And we're typically very good in machine learning in assessing whether a tool has successfully predicted our outcome of interest. And sometimes we're really good at saying if it predicts better than the previous tool that was in use or other tools. But the process of implementation is not really well evaluated in the literature to date. There are a few studies that are out there that have looked qualitatively, that have looked really at the implementation and how things are being used. So when I talk about implementation, it's really, how are the tools implemented? Who was involved in the implementation? How did workflows change? What did the people who use the output from the tools, what did they think about them? How did they trust them? Are they usable? Are they effective? Are they acceptable to the population? So when we think about evaluation, ideally, especially in the qualitative side, the evaluation should be independent from the people that develop the tools. This is just so that, it's just seen as more objective, obviously. And so we really think about, so how do we evaluate? And there's many, many, many different ways to evaluate. And I could spend a day just on this slide alone, but this is an adaptation from the CDC framework for evaluation. And it's really meant for programs, and I've adapted it just a little bit. But in general, when we think about implementing a program or a machine learning tool, we want to think about engaging stakeholders, designing an evaluation, implementing the program or the tool, gathering and analyzing data, and then summarizing and disseminating findings. And that last piece is really important because we want to share what lessons we learn with other people so that everybody is not reinventing the wheel every single time we do a study. And in there is evaluation, right? And evaluation, it's great if it's quantitative, but even better if it's a mix of methods. And when I say qualitative, I mean, how is the program or tool implemented? As I mentioned before, we can do observations, we can do interviews, we can do focus groups, we can do a plethora of different things. And when I talk about the quantitative piece, we're thinking about what outcomes were achieved. These are changes in process measures like tests or changes in outcome measures like mortality, just for example. And then I created this little diagram just to think through how we can think of evaluation in terms of the machine learning process. And if you look at the machine learning embedded system lifecycle on the top, we have several different steps, and people might have different, this could be tweaked. But so we've got the step 1 of identifying needs for clinical optimization, and then several steps within that. Step 2 of designing the product, and several steps within that. Step 3, implementing the product, and several pieces or components within that. And then step 4 of maintaining or improving. So was it useful, not useful? If it's not useful, we should de-implement. So along each one of those steps, we can embed evaluation as part of it. And we can embed a qualitative team here. In step 1, we can observe stakeholder meetings, review meeting minutes, we can observe workflows, we can assess digital literacy. In step 2, again, we could do observation. We could conduct interviews, focus groups with clinicians that are the end users of the products. We could do co-design workshops so that as data science teams start developing products that we know that they're useful, that the people who are going to use them are giving input into the interfaces and how their things look like so that they're actually user friendly. And in step 3, we can assess clinical implementation. So we can observe changes and document the changes. This is one big thing. I think we often, when we implement things, we make changes along the way, but they're not really documented in a formal way. And, that requires us to have the people that were involved there all the time, right? To ask questions to. But if we write those things down, if we write the changes that were made, that took place, if we write them down and we share them, then other people can learn from them. We can also conduct surveys, interviews, focus groups to assess user experience and feasibility and implementation. And this is what we spent a lot of time doing in the study I'm going to spend some time talking about. And then we can assess outcomes, which I mentioned before, quantitative and qualitative outcomes. And then at the bottom here, this is all data analysis and summarization. Everything feeds back into each other. And, and we then disseminate the findings. This is obviously an ideal, and I'll tell you, it almost never happens. Ideally, it happens prospectively. Evaluation happens prospectively. We use a mix of methods. In reality, I'll say it almost never happens prospectively, and we almost never use all of these different methods. It's expensive. It requires forward thinking. But I would say that any evaluation is better than no evaluation. And so we didn't, in this study I'm going to talk about, we didn't use every single one of these things, but we used some of them. And so that's what I wanted to share. So at Mount Sinai, we have many different machine learning CDSS systems that are used to predict things like clinical deterioration, in-hospital mortality, transfer to the ICU. We also have a system for falls. And the one I'm going to talk about today is for malnutrition. And this system is called MUST+. And MUST stands for the Malnutrition Universal Screening Tool. And there is a tool called MUST, and it's been used for years. It's used across the United States, probably the world. There are other tools, but it's a screening tool for malnutrition. And the machine learning version of that, we call it MUST+. And malnutrition is incredibly important. It's very prevalent in hospitalized patients. It's, the prevalence ranges and it's not exactly known, but it's thought to occur in about a third of hospitalized patients. So, and it's been historically very underdiagnosed. Malnutrition is associated with higher morbidity, mortality, length of stay, which of course has cost implications for the hospital, delayed recovery, et cetera. It's early detection of malnutrition is incredibly important for treatment, right? We want to detect it early. We want to get people into treatment because it is treatable in many, many cases. It's also in the hospital setting, screening is mandated. So the Joint Commission requires that all hospitals screen for malnutrition as part of the admissions process. And the global leadership Institute on Malnutrition, also known as GLIM, developed a universal framework for assessing malnutrition through a two-step process of screening and of assessment by a registered dietitian. So machine learning technology is very appealing for malnutrition because we can't possibly screen everyone by a nurse doing it, right? There are so many patients. At Mount Sinai, we have thousands and thousands of patients. I didn't give you any background on Mount Sinai, but for those of you who don't know, it's a huge urban healthcare system with many, many different hospitals. And so it's very appealing to use some sort of tool to screen automatically using electronic health records, which is what we did in our hospital. So having a tool to screen patients, even if it's an imperfect tool, is better than no tool, so that we, nurses are amazing, right? But they don't have the capacity to screen everybody, and they're not perfect at recording data. So if we can use a tool like a machine learning tool, great. But we have the responsibility, as I mentioned earlier, of evaluating that tool and sharing the lessons that we learned about how the tool was implemented. So I mentioned that the screening tool that we use is called MUST Plus. So it's a play on the original MUST, which is a hand-based tool where a nurse is checking off boxes, BMI and height and weight and that sort of things. So we developed and implemented and evaluated MUST Plus. And in phase 1, it was a quantitative study. And what we did for that, and I have the citation, that's citation number 1 down here that you see. It was a retrospective cohort. We developed, implemented, and evaluated the machine learning tool. So we used 8,500 patients in a retrospective cohort with a test set and a training set and a test set. And we found that MUST Plus was superior to MUST, which is the traditional tool. Also, I'd like to point out that MUST Plus, and you'll see this later, is rerun at regular interviews where the traditional MUST is only done once. So we have that advantage. It's done automatically. And when I say it's superior, the data were quite clear. So in terms of the AOC, ROC, it was 75% higher than MUST. In terms of sensitivity, 30% higher, specificity, 6% higher. And in terms of the F1 score, 40% higher. So it was very clearly a better tool than what we were using. Not perfect, but better. And so that led to the implementation of MUST Plus, the machine learning screening tool, in multiple facilities. So at first it was only implemented in our main hospital, which we call Mount Sinai Hospital. And then over a 2-year period, it was rolled out or scaled up into 5 other hospitals within the Mount Sinai system. And then the second part of the evaluation, which is where I will spend the most of the time talking about today, the methods and our results, is this evaluation of the implementation within the clinical workflow of registered dietitians. And they're the ones that they get that MUST Plus score every day, and they use it in their clinical practice. And I won't talk about that right now because I do want to mention just the phase 3. So phase 1 was quantitative, phase 2 qualitative, phase 3 quantitative. And phase 3 is where we're really looking at the outcomes. We're assessing admission to diagnosis lag, the usability rate, documentation rate. And this is using prospective data across all of the 6 facilities. So not just the original hospital. So, the usability is, it's really important. It's a measure of whether RDs are actually using the score in their everyday practice. And then we have the success rate, which is, how often is an RD actually, we consider the registered dietitian the gold standard. How often, when they see a patient that is considered high risk by the tool, how often are they actually diagnosed with being malnourished? And then documentation is another thing that we look at. And so it's not enough really for the dietitian to say, yes, they're malnourished. They also have to document that in multiple places. And then a clinician has to sort of sign off on that documentation in order for the hospital to be reimbursed. So it has, again, cost implications, right? And so part of the goal is to really increase documentation across over time. And so the phase 3 study that's been submitted for publication in the Journal of parenteral and enteral nutrition. So that's not published yet, but I just, wanted to give you sort of like a little preview, but it really, the MUS+ system really did have great impacts on all of those things, on productivity, so usability, success rate, and documentation, and also on impact. The diagnosis from the admission to diagnosis lag was decreased, so people are being seen faster, and the malnutrition rate, we're able to diagnose malnutrition more often now with this machine learning screening tool than we were before. So moving on to phase 2, which is the qualitative piece. That's where we'll spend most of the time. So the goal was to evaluate the implementation of MUS+ and to identify best practices, and of course, to share lessons learned. And what we did is, it was considered a post-implementation qualitative evaluation. I mentioned before, it's lovely to do things prospectively, but it often doesn't happen. And so this evaluation happened a little while after the go live dates for the different hospitals. And so we interviewed registered dietitians that were involved in that use the output from the machine learning tool in their everyday work. We interviewed 17 dietitians across many different hospitals, and we selected the respondents very purposefully. We wanted to have variation across the different hospitals. We wanted to have variation across the staff levels. And that's like clinical nutritionist, dietitian versus senior dietitian versus clinical nutrition coordinators versus advanced coordinators, because those people have different, different knowledge, different training, and different years of experience, and also the model version that they had implemented. So many of the hospitals implemented 2 different versions of this model. So the model was improved over time, and we wanted to ensure that we had variation across hospitals that had implemented both versions. We wanted to ask specific questions about that. I think 2 of the hospitals only implemented the later version because they came on later. They were sort of brought on over a rolling time period. And I'll talk to you a little bit more about the sample on the next slide, but I just wanted to show, so these are our different hospitals. There are a total of 46 registered dietitians across the hospitals. And we approached 24 of them, and we interviewed 17 of them. So about a little bit more than a third. One hospital, and it was one of the smaller hospitals, we didn't have response from them, and we weren't really pushing them, and it would have been great to have information from them, but we weren't able to get it. So these are the sample characteristics. I mentioned that first part. So we had about a 71% response rate, which was great. Nobody refused. It was just a lack of response. And we had representation from 5 of the 6 hospitals, but I'll point you to that last part. So the years that RDs had worked at the hospital, the range was from 1 to 15, with a mean of 4 and a median of 2. So we did get some variation there, which is great. In terms of the interviews, they were done via Zoom. And I'll also point out that we went through the IRB, but this was considered an exempt protocol. Excuse me, drink of water. Okay, so we did the interviews via Zoom. They lasted about 40 minutes. We obviously scheduled them at times that were convenient for registered dietitians. The interviews were done by 3 different people, Dr. Ksenia Gorbenko, who's on the call with me today, myself, and then we also had a student from Michigan helping us do some of them, and she did a lot of coding of the interviews, which was great. And we used a semi-structured interview guide. And we had guide domains that we used the different team. We used our registered dietitians, a lot of the different people on the team to help us come up with the guide. We asked questions. These are the domains of the guide: background, workflow, training and rollout, understanding of MUS+, usefulness, perceived accuracy, physician trust of the RD assessment, and suggested improvements. So in terms of saturation of knowledge, I mentioned that we talked to 17 clinicians, 17 registered dietitians. At about interview 11, we had already saturated knowledge. In other words, we weren't getting any new information, but we continued to interview people because we wanted to ensure that we had variation across those things that I mentioned before, specifically across hospitals. We wanted to be sure that we had representation from as many of the hospitals as we could get. So I don't know the background of everybody on the call, so I'm just going to go through sort of this qualitative process of what we did. So once all of the interviews were recorded with permission of the registered dietitians. And then we had them transcribed. We used Temi online software to transcribe them. And then we did our coding using In Vivo, which is a standard qualitative software. So what you can imagine is we've got a transcript of verbatim with every et cetera in there, which we ignore. And we go through and line by line, we develop a code for every line that we think. Okay, and I'm going to tell you what codes are in a second, but every one of the 3 people that we're interviewing, we coded the first transcript independently, and then we got together and we came up with preliminary codes, and we developed a preliminary code book. Then we had our student go through the second transcript and code that, revise the codes that we came up with in the first transcript, add codes as knowledge was gained and people gave different answers. Then we met weekly to talk about the codes and discuss if there were any, questions. Should we change this code to this or this code to that? What do we think about this? What do we think about this idea? And this was an iterative process. And at about transcript number 5, the code book stabilized. In other words, we weren't adding any more codes. We had sort of, that was it for the codes. So once we had finalized the code book, we went back through all of the other interviews and recoded them so that we were sure that we had consistent coding throughout. And these are standard qualitative methods that we do, but just in case people aren't familiar with them, I wanted to describe them a little bit. And we coded, and on. And then we coded the remaining transcripts. And then we all coded again, one transcript together to ensure that we had intercoder reliability. So just to give you an example of this is a page from the final code book. So on the left, we have a code, and on the right, we have a description of what would go into that code. So imagine us going through the text and picking out, coding something as, for example, workflow. So we would code anything that would talk about workflow throughout the day, daily tasks, the orders that they do, the order that they do things in, that sort of stuff would all get highlighted in the text and be called workflow. And the codes are, in qualitative research, are a way to look through the data, whereas the themes emerge from these codes. And themes are really theoretical concepts that tell us a story about the data that we're seeing. So after we were done with the coding, the transcription and the coding, we used the NASSS framework, which is non-adoption, abandonment, scale up, spread, and sustainability. This is we use this to help organize our themes into different areas. And this is NASSS, for those of you who aren't familiar, I put the citation down here for you. It's a theory-informed, evidence-based, pragmatic framework. It has 7 domains, which are the condition, the organization, the technology, the value proposition, the adopter system, the wider societal context, and then the policy context. And the NASSS framework proposes that it's really not an individual factor that would make or break a technology. So this framework is specific to technology implementation, like machine learning technology. It's not the individual components that would make or break the technology, but the the sort of interaction between them. So this is kind of important. And so the framework posits that something that's characterized, or programs or tools that are characterized as complicated, could be difficult to implement, but not impossible. But those that are characterized as complex on multiple domains will almost never be successful. They'll be abandoned. And so we did this sort of after the fact. We used it to help us organize our themes, and it was great. It would have been great to do it a priori before when we developed our guide, but it was still useful to us. And so when we went through the data, we had some, much of our data fell into many of these domains, but we didn't have representation from all of them. So going on to the results, in terms of the NASSS framework, and thinking about organization, and when I say organization, I mean how ready is the organization for ready for the technology, what changes will need to be made among the team, interactions and routines, who was involved in implementation. So one of the themes, workflow, we put into this framework domain, organization. And so this diagram describes how the MUS+ score fits within the RD workflow. So you see it's like this profiling happens in the background. The prediction score pops up in Epic, which is our electronic health record system that the registered dietitians use. They get that score, which is a range from 0 to 1, and there's a threshold that they're supposed to use at each hospital for which they would go see a patient. So they use the score to prioritize their patients. Then they go and they review their charts. And prioritization is based on the score, but it's also a little bit based on the location of the patient. So if patients are all over different floors, they're obviously going to try to meet with patients on the same floor, at one time. So they prioritize patients, they review charts, then they go in and meet with the patients, they conduct a nutritional assessment, including a physical exam. They give a diagnosis of malnutrition. If no, they document that in an Epic flow sheet. It gets suppressed for 3 days and pops back into the system. So it happens again, and it goes through that repeatedly. Whereas the original MUST would never do that. You would just get the screening once. So this is an advantage of the system. If an RD says that a patient is malnourished, they document into a flow sheet in 2 different places, one for coding for payment for the hospital, and then an intervention is provided, and eventually the patient is discharged. So another theme that we came up with was provider communication and trust. And we actually learned that most of the communication between the registered dietitians who do the assessments and give the diagnosis, and then the provider, in New York State, a physician actually has to give the formal diagnosis for payment for the ICD-9 code. And so RDs have to communicate what their diagnosis is, malnourished or not, with the physicians. And so most of that is happening via this secure Epic chat. So that was something that we learned. In-person communication is happening, but it's happening much less common, and usually for patients that they're very, very worried about. They might sort of hunt down a physician and say, hey, I need you to look at this person. One thing that we were pleasantly, not surprised, but we were happy to see is that the relationships between RDs and physicians was actually very positive. That for the most part, physicians trusted the RD diagnosis. There was some old school beliefs about nutrition that, for example, low albumin always equals malnutrition. And so some of the older physicians were sort of, pushing RDs, and some of them didn't really value nutrition. But this was pretty rare, and it didn't happen very often at all. I think we heard that maybe Ksenia and I maybe twice across all of the interviews. And that in general, younger physicians were actually really open to education. And so they might not know everything about nutrition, but they were really curious to learn more, which was great. And then turning to the value proposition, which is what's the desirability, efficacy, safety, and cost effectiveness of the technology. So under here, we put a couple of different themes. One of them was usefulness, and this is a really important theme, obviously, because we want RDs to find the data output useful. And all of them did report that the score was useful. They used it to help prioritize their work. In other words, which patients they would see in what order. But the degree of usefulness definitely varied by respondent. And the original hospital, Mount Sinai Hospital, where we implemented it, they tended to think that the output from the tool was more useful. And I'll talk a little bit more about this later. In general, everybody thought that the score was objective. It was based on real data, and they really valued that. They also noted multiple times that MUST Plus was identifying different patients than their traditional screening, and they thought that was great. They noted, almost everybody noted that the score cannot be used in isolation, that even though it's good and useful, it's not perfect, and that they still need to do those assessments and the chart reviews and that sort of stuff. And these are just some usefulness quotes. I love quotes. I think it definitely helps capture any patient that's not screened by the nurse. Nursing staff is not 100% accurate. Sometimes they can miss things or inaccurately fill out their screening tool. So I think it's helpful to have the predictive score. Another quote, I think it's very helpful because we're catching these patients that we wouldn't necessarily see until day 6, much earlier than we would have. So that's actually really amazing that's at least the perception. Okay, in terms of accuracy, now we didn't measure accuracy, but we asked the RDs how accurate they thought the scores were, and it was perceived that they were between 50 and 70% accurate. Everybody that's worked with multiple versions of the tool said version 2 is definitely better than version 1, and a lot of them had input on how to make version 2 better. There was a lot of feedback, a lot of working with the RDs, especially at the first couple of hospitals, to try to improve the tool, and feeding in, once the RD assessment came in, feeding into the system the gold standard assessment and making the tool smarter. In terms of accuracy, RDs perceived that accuracy was affected by several different factors. One was definitely human error in data entry. They would see weird scores here and there, missing like crazy weights or some odd values. And also they noted that the data are run at the standard times every day, and sometimes data are missing. So they're being run on partially missing data. And that was, that affected accuracy. The other thing that was super interesting is that RDs noted that there were accuracy was affected by things like weight extremes. So elderly patients that were really thin, Asian patients they noted that were often thin, that it wasn't accurate for them. And then amputees, because obviously BMI is one of the things that's fed into the system, that is not meaningful for those populations. And so they sort of thought, we asked specifically about bias. Did they think there was bias in any of it? And this is where potential bias came up. And I will say that this will be another paper, but we did check for bias. There really is no racial ethnic bias in the system. But there is this idea that there is bias, right? So if perception is all, reality is nothing, right? So if RDs perceive that there's bias in the system, they don't trust the score as much. So we have to really think about that when we design these systems, like how can we change that perception, because we want them to trust the score. Other factors that they thought affected accuracy were albumin levels, fluid overload, anemia from a bleed, low platelets, etc. And I didn't mention this before, but once they get that score from 0 to 1, there's also a hover tool that they can use, and not everybody used it. Everybody knew it was there, but not everybody used it. They did use it, very interestingly, when they didn't trust the score. So they went in and said, okay, what's feeding the score? It lists the top factors that are causing the score to be high, right? And those factors change based on patient. And so they were often using that tool for checking whether or not they trust the score. And if it was like weight, and they would go into the weight and they would see the weight was something crazy, they just wouldn't trust it. And then they would, maybe not see that patient, or they would really, rethink how much they trusted it. In terms of autonomy, so everybody liked the score, everybody thought it was valuable. They used it to prioritize who they would see. But they really still wanted their own autonomy. So in cases where they didn't trust the score, they wanted to not have to really visit those patients. So that's something to keep in mind, that clinicians do want autonomy, and we need to be very clear that the machines will not replace the clinicians. I mean, the clinician is the gold standard. This is just a way of having them save time so that they don't have to see every single patient. And just highlighting that to clinicians, I think, would allay some fears that people have. In terms of understanding, and this is where we talk about it, that NASS framework domain is the adopter system. And this is, what changes in staff roles, practices, and identities are implied. And so we put the theme that we came up with, understanding, under this adopter system domain. Everybody understood the basics of how the machine learning worked. They don't understand decision trees. None of them do. That's fine. I don't really even understand them fully. But they understood sort of what, that there are different factors that feed into this, that we're using objective data from labs, from, different inputs to feed into this model. We're getting, different scores for different people. So they had an understanding of it, all of them, but the understanding was definitely deeper among staff at the first hospital of implementation and among the higher level staff. So those clinical nutrition coordinators. And this is evidenced, one of the things that one of the quotes is, I wish I knew exactly how it worked, in other words, the system, or how the algorithm captures these patients. So they wanted to learn more. They were interested in learning more. And then they had a lot of questions when we asked them, these questions came out. What exactly determines a high score? What exactly changed between version 1 and version 2 of the models, other than raising the threshold? Do factors like albumin, platelets, and hemoglobin all carry the same weight in the model? So this suggests that they might understand the basics, but there's a deeper knowledge that's sort of missing. And again, the first hospital and the higher level staff had this deeper understanding. In terms of patient communication, workload, and staffing, RDs noted that the way that they communicate with patients did not change at all. And that was kind of nice to see. They weren't telling people, oh, you have a high score. That was never mentioned. It was really just changing how they prioritize patients and who they pick to go see. The amount of time also with the patients has not changed. And here, this is the quote: the score is less defining how long we're spending with patients and more defining who we're seeing. I do think it's helping us capture malnutrition in patients earlier. In terms of workload, which is something we always need to consider, workload, people definitely noted had increased. And that, a lot of this was implemented during COVID. So staffing at some of the hospitals was really, was tough in some places. And I think so some of the comments about workload could be reflective of that. But let me read this quote. But sometimes we're reading through the chart, we're looking at a patient's BMI, and we don't think they're going to be malnourished. So sometimes those patients do have a high NPS. That was a predictive score. That was what some hospitals called it. But their BMI is very high. And we're reading through the chart and where we have a very low suspicion of malnutrition. So sometimes it can add to the workload in a way that the patient is probably not very high risk and they could have waited. And so this is where the RDs really wanted to not only consider staffing, but really consider having that autonomy to choose when they would see the patient. Like not every single time, they obviously trusted the score, but sometimes they were really, they didn't believe in it. So considering staffing obviously is important. In terms of the NASSS framework, embedding and adapting a system over time, we put in this theme: dissemination, suggested opportunities for improvement. So in the original hospital, everybody learned about the model, learned about MUST+ from the data science team. Okay. And then as it was rolled out in hospitals, the data science team met with key staff at the hospital, but not all of the RDs. Obviously, it's more efficient not to do that. But the problem is that they may be explaining it differently. And so my sense, and I can't say this with certainty, but my sense is that there was sort of a lack of, a lack of the ability to explain it in a way that was had the same meaning as the data science team explained it. So I think this depth of understanding really varied when you didn't have the data science team explaining to the RDs how the system worked, why it worked. In terms of ideas for improvement, the staff really wanted to change the weight of factors that feed the engine. And of course, I think this goes to show that, they don't understand decision trees. And then they wanted the score only run when all data were present. So I'll just read this quote to you. Sometimes if that patient was just recently admitted, the particular identifiers were null because they haven't been completed just yet. Even with the missing information, sometimes a score is generated. But if there was a way that the score didn't generate until all of the appropriate information was found or completed in order to get more accurate score, that would be helpful. So they wanted it not to be run if data were missing, because obviously they don't want to waste time seeing people that really shouldn't be seen. And then another idea for improvement is that they really only want to use one screening tool. So the goal obviously is to replace MUST+, to use MUST+ and not use the other screening tools that they were using. But right now, even still a couple of years later, every hospital is still using a paper-based screening tool in addition to MUST+. And the goal is to eventually get rid of that other tool. So you can see this quote. Right now, it feels like we have so many screening tools. If there was the ability to kind of streamline it, or to just say the prediction model and not the MST, that was another tool that they're using in addition to it. Obviously people want what's more simple, and it's kind of a waste of time for them to look at multiple tools. So if one tool is really great, let's drop the other tools. And that's eventually the goal. And I think we're headed there. In terms of advice for other sites, so that at the end of the interview, RDs were asked, what else would you tell other sites that wanted to implement this or something similar? And they said, really look at the big picture of malnutrition, not just the score. Like the big picture is what's really important, and the score is one piece of that puzzle that's going to help us identify who to see and prioritize so that we don't have to see everybody. And they also talked a lot about starting slow and testing the tool, which we obviously did in this case, and considering staffing. That was another one of the things that came up over and over. So in terms of implications, Obviously, further tool improvements are possible, and we've got to really delve into the inaccuracies of the tool and the potential for bias, which we've done. And I don't have those, I'm not going to share those data today, but that's something that everybody really needs to consider. Can be a lot of existing bias in healthcare data that are feeding these machine learning engines, and so we need to really think about that and really be sure that we test for that, so that we don't continue to have bias in the systems. Or make it worse, obviously. And then obviously, we would love to get rid of other screening tools to make life easier. And then I think one of the biggest take-home messages from this study, and there's no way we would have gotten this without doing a qualitative aspect of the study, the quantitative pieces would never have revealed this, is that that you really do need continued stakeholder education over time, because information is lost. So as I mentioned earlier, when the data science team is not training but the staff, and you have staff training other staff, something is definitely lost in the understanding, the trust of the system. And that really has, that has implications for how much it's being used. And, obviously we want to know, where we want to have a system that's going to be the most useful for the end users, right? We don't want people to lack trust in the system. So that's the end of my talk. I've left plenty of time, I think, for questions, and I'm hoping I didn't skip over anything massive, but I'm sure you guys will have questions. We've obviously plenty of people to thank, the 17 dietitians who participated in the interviews. And I will say we had intended to interview other people, but when we talked to the dietitians, and asked who else was involved in looking at the score and in the implementation process, other than the data science team, there was nobody, and the data science team was part of our research team. So we only interviewed the dietitians. And then obviously the clinical data science team who developed, tested, and implemented MUST+. We have to give thanks to them. So that concludes my talk. If anybody has questions, I'd be happy to discuss.
Thanks for the excellent presentation. It's always good to see connections between the machine learning data side and how it impacts patients. I'm wondering, you may have addressed this during your talk. I'm wondering, do physicians know that this is being used, or this is happening at the RD level, and so they don't necessarily know that this is happening?
It's a great question. And Ksenia, maybe you know better than I do, but my sense is that they know that it's being used, that RDs are the primary people that use it, but they are aware. They were brought in, obviously if they're new clinicians, I'm not sure what they know or don't know, new physicians. But really the target is really those registered dietitians, and the registered dietitians give the formal assessment, which is the gold standard, not the score. But my understanding is that they are aware that this exists and it's being used.
I'll just add, I'm not so sure whether they know or not, because especially, you have a lot of trainees, residents, but we did have actually a whole theme in these interviews where dietitians talked about their communication to the doctors, because they basically assess, and when they diagnose malnutrition, the doctor has to sign off. And sometimes the doctor, there's sometimes some pushback, and they talked about educating the physicians who are of the older generation, who may not know the latest guidelines. It was really interesting. Yeah, that could be a whole other paper.
And there's a related question from this. How challenging is it to integrate your ML model into the patient portal or the doctor's system for data entry?
Oh my gosh, I don't know the answer to that at all. That would be the data science team. It's a very good question. I think it actually, from my understanding, they worked very hard to get it in there, and it is an integral part of Epic now, and it runs very smoothly. But what it took to get there, I can't say. I wasn't part of that process. I'm sure it was not easy, but it is part of Epic, as are all of the other machine learning tools that we use for the other outcomes like falls and mortality. So they are all part of Epic now.
To clarify your last statement, are you saying that this is available to all Epic sites, or just as an add-on in your Epic site?
In our Epic site, sorry, everything is built. It's like a homegrown built every one of these models is homegrown and built into our Epic system. So the scores for the different, as I mentioned like much earlier, we have a lot of different systems that are being used, and malnutrition is just one of them. But my understanding is that they're all built into Epic. So scores pop up automatically into Epic for the clinicians to see for all of the different pieces. Oops.
Hey, Melanie, I'm from Radiology, Vice Chair of Innovation, Co-Direct AI. I really liked your talk and I appreciated how you iterated on this. So that's not just like a concept and we're just going to go build it and push it on things. You really took a lot of feedback with that. So it was very interesting concept to do that. And it sounds like you're integrating it into Epic, and that's obviously, I think part of the question we just heard is why can't we do that here too? You know, when we're asking about, is this available on other sites? One thing I was thinking about too, it sounds like this is kind of an example of opportunistic screening, which is sort of repurposing a visit for another cause. So they're coming in for whatever they're coming here for, pain, foot hurts, I don't know what they're doing, but you're then applying this tool to them and identifying malnutrition. We do something similar in radiology, so I'm throwing it out there that there may be some potential for a collaboration where we run body composition analysis algorithms on patients in a fully automated way, so we could calculate their abdominal fat, muscle, bone density, et cetera. And I know that's a smaller population than ultimately what you're going after. You're essentially, it sounds like you could hit almost every clinical visit potentially here, but just something to think about. So I'll follow up with an email about you as a potential collaboration that could form out of this.
Thank you. Thank you. And just to clarify, so these aren't all clinical visits. These are all people that are they're hospitalized. So they're in hospital, right? But for sure. And I will connect you to our data science. So I'm not a data scientist. I'm an epidemiologist and a qualitative mixed methods researcher. But for sure, there's definitely, it sounds, your project seems really, really neat. So Arash Kia is one of the people that I'll definitely help connect you to.
Sounds good.
Yeah, for sure.
Can I add something to this? I think also just to clarify that this idea came up as a way to actually increase reimbursement, because if an inpatient has more than one diagnosis, like I think, or more than two, and malnutrition could be one of them, there potentially was like a higher reimbursement rate from CMS. And I think the jury is still out whether we actually saved any money using this tool, but that was the impetus.
Yes. And it's hard to measure the cost, I think, because at some point you can only have a certain number and then you don't get paid above that. And the cost data are really messy. But yes, it's a good point. Thank you, Ksenia.
You mentioned the phase 3 evaluation, the quantitative evaluation, which is the outcomes. So I'm guessing that is started or in process now, and maybe the results of that might drive a wider adoption, or making it more easily available in Epic to other sites.
Yeah, so it's that evaluation is actually complete. So we know we've submitted it for publication already. And I helped write that paper, but I did not do the analysis on it. But that's looking at the productivity, so the usability rate, the success rate, the documentation rate, and also the impact, so the admission to diagnosis lag and the malnutrition rate. And all of them were improved pre and post. And then, so we did a pre-post study at Mount Sinai Hospital, so the main hospital. And then we also looked at the 5 other hospitals. So that was a prospective study, which was kind of neat. And I don't have the publication here. It hasn't been accepted yet, but we're in the process of getting that one out there. But for sure, I think as we publish more of these, more people can sort of pick up on and learn from them and try to do something similar. Everybody's electronic health records are set up differently, but lots of hospitals have data science teams that can learn from each other. And, there's lots of potential for cross collaboration.
Oh, okay, right. Yeah. And I know there are a lot of data science people on the call, so I'm sure everybody would be happy to see how those results are. And it's kind of unusual to have to combine machine learning or data science with qualitative research methods, but that's the best way, or a good way to just find out how the users are being impacted. So maybe that's just plug for qualitative and evaluation.
For sure. I mean, Ksenia and I love it because that's what we do. I mean, I've done a lot of analysis too back in the day, but I think you just learn different things. They're both really important pieces of the evaluation, but to have that really comprehensive picture, because if you only have the outcomes, but the people using it don't trust it, you don't really know what you're getting, right? So it's just, it adds a different layer of understanding of how the overall system is working.
Yeah, and you're also missing all the nuances.
Yeah.
Well, we still have a few minutes. If anybody else has any burning questions or comments, probably lots of opportunities for collaboration as well.
Sure, and I'll just say this paper was the paper that I presented, the qualitative paper, will be published in J. Muir's Formative Research in the coming months. So I think I put a citation in there, like the preprint. I don't even know if you can access it, but you can at least see it. Because there's a lot more detail about how we use NASS and the more detail on the methods. I didn't get into the nitty gritty, but there's a lot more detail on the results. I tried to give sort of an overview of them, but ideas for improvement. And really, we talk a lot about the training of the RDs and what it took to get them up to speed and how that whole process took place. A lot that's detailed more in the paper than I was able to talk about today. So I encourage you, to, if you can access the preprint based on whatever I put in there, go for it. But otherwise, it'll be coming out in the coming months. And then stay tuned for phase 3. It's done and written and in, but we'll see.
And we can probably share the paper, right? Can we share the paper if people need it?
The second one, yeah, I put the preprint citation in there.
Okay.
Yeah, so I think you can click on that and access it, but I'm not totally sure. I didn't try to cut and paste it back out. And then the first paper, how the model was built, that citation is there, and that's been published for quite a few years now. So.
Any final questions, comments? You chat or unmute yourself. We are among friends here. Oh, here's a question. Thank you for this very interesting presentation. You mentioned that not all RDs interviewed had used both versions. Some were brought in later, only used version 2. Do you know if perceived accuracy or usefulness based on whether RD had used both versions?
Do we know if perceived accuracy or usefulness? So I would say everybody said that accuracy and usefulness were better with version 2. If that's your question, I'm not sure. Is that what you're asking? Josh, if you want to speak up.
Yes, I was asking if they had differed based on whether an RD had used both versions. Sorry about that.
Yes, for sure. Everybody said version 2 was better. And the data showed that it was better too. I mean, it was a more accurate model because it was being fed in. So as the model was being rolled out, it was improved over time. And so every time an RD did the assessment, that, their gold standard, their assessment, yes, they're malnourished, no, they're not, that was fed back into the system to make it smarter. And so not surprisingly, everybody that used 2 versions of the model said it was a better model, said it was more useful and more accurate.
I also do remember that there was one hospital where all the interviewed RDs had a lower perceived accuracy than every other hospital. And we talked about this with the data science team. I think the local data does affect it, and maybe it was just a particular small hospital. So the model was not working as well within, and they were like, it's a little over 50%. Like they were like, it's not as great. All the other places were like, oh, it's pretty accurate. Like all the other ones were like trusting it a lot more.
Yeah. So I put my email on that last slide. I shared my slides before, so everybody can just shoot me an email if you have any questions or further thoughts or collaboration, and I can connect you anybody necessary.
Yeah, Dr. Besculides also shared her slides with me. So if anybody has trouble getting a hold of her, you can reach out to me, and I can also send you those slides. There was someone who contacted me and said, "Oh, I really would love to have those slides." And so since your work is already going to be published, I guess thank you for sharing that.
Yeah, no problem. That's great. Thank you.
Yeah, I mean, it's not only for this study specifically, but just in general, good to for just doing qualitative research. Yeah.
Perfect.
Any other comments or questions? We're 5 minutes now from 11 Central. Well, hearing none, then thank you very much for a very enlightening, interesting, impactful presentation on important work affecting patients. And thank you all for attending. Have a great weekend. Hope to see you at the next Power Talk.
Thank you so much. It was a pleasure to be able to speak with you, and I appreciate all the questions and interest. Have a great day, everyone.